Good evening and welcome to our webinar on ADPKD in children and young people. It's my great pleasure to introduce Dr. Matko Marlais. Matko is a consultant paediatric nephrologist at Great Ormond Street Hospital for Children. He also wrote the booklet ADPKD in children and young people, which is available on our website.
Thank you very much for that, Tess, and thank you everyone for attending tonight. I can see the first Q&A about the background noise. Hopefully that's now been resolved with muting, but if it continues to be a problem, please do let us know. Please do ask questions. I'll try and go through them at each point in the talk. And as advertised, I'm going to talk to you today about ADPKD in children and young people, which is a particular area of interest of mine, both clinically and in research. And thank you to Tess for all the work she's done with us, because we've been working in our research group with Tess for the last 7-8 years, and her expertise and that of the PKD charity has been really valuable as we try to improve the knowledge around the subject for children and young people with this condition. So I'm just going to move these slides on. So the things I plan to talk about today are related particularly to issues that we see in a lot of the families that we see in clinic. We have a reasonably high number of children in our clinics at Great Ormond Street and across the paediatric nephrology centres, but actually most children with this condition don't see a paediatric nephrologist, and most of them aren't diagnosed. We'll talk about if there's any reason to diagnose ADPKD in children or young people. And we'll also talk a bit about whether we should be monitoring blood pressure in those who have ADPKD and those at risk of it. Another common question we get is about diagnosis and how we diagnose it in children and young people, and if families and young people choose to be diagnosed, how we would do that. I'll talk a little bit about potential treatments and the things that we might see in the future, and I'll finish on COVID-19 because that's clearly something that people are worried about at the moment and something we get asked a lot about in clinic. So up until 2018, there were no guidelines in the UK or really internationally to give comprehensive advice on the management of ADPKD in children and young people. So colleagues about 5 or 6 years ago now undertook a survey of the UK management of this condition to try and get an idea of what paediatric nephrologists in the UK were doing. And they did that with some example cases, and these colleagues were the ones that did it with the PKD charity. And respondents were from across the UK, so lots of different centres got involved. And amongst other things, what we found is a significant inconsistency and variability in the practice of different clinicians with this condition. And this is just one of the examples of the data from that survey, showing that some people would see children and young people with ADPKD every 6 months, and some people would only see them every 5 years. And we felt that this kind of inconsistency wasn't what we wanted going forward. We wanted people to be following a reasonably clear set of guidelines. And so in view of this, a group of us got together and we formed this guideline working group with the British Association of Paediatric Nephrology and the Renal Association to try and get a clearer idea of what the evidence, the scientific evidence in this condition is, and to try and make some guidelines so that all clinicians who see families, children and young people with this condition should be doing. So this is the published guideline, which you can find online, and I'll provide a link to it later. I'll just run you through some of the key recommendations from that, because I think it is important and it illustrates some of the discussions we have with children and their families in our clinics. So these are a summary of the 6 main recommendations. The first one, to many people, feels like common sense, but actually, if you delve a bit deeper, it's quite important. So we recommend that patients and carers of children and young people at risk of developing ADPKD should be offered information on the inheritance of the condition and the potential benefits and harms of testing for ADPKD by health professionals with specific knowledge in this area. And that's important because a lot of families were being told things that are now considered to be relatively outdated. So when I was at medical school, we learned about this condition and we called it adult PKD, contrasted with AR PKD, which was considered childhood PKD. And we now know, and I'll come on to this later, that there are a substantial number of children who do have manifestations of ADPKD during childhood. Therefore, it's no longer appropriate to think of it as adult PKD. But unfortunately, lots of clinicians, often those seeing the adults with this condition, will call this an adult condition and will simply say that children and young people shouldn't be tested for it. And I'll come on to what we think about that in a minute. But the key aspect of this recommendation is that families and children and young people who have this condition should be given clear guidance and discussion about the different types of testing, if they're interested in doing that, and the pitfalls of such testing in children. Testing for the condition isn't straightforward in children, and so we feel that those who seek that information should be given that by specialists who know about this condition in detail. I'm just going to go to Q's and A's. I've just got a question there, so I might just hold that one to a little bit later if that's okay. So the second recommendation is that we recommend that children and young people aged 5 years and above who are at risk of developing ADPKD should have an assessment of their blood pressure at least once every 2 years. Now, the European guidelines and the international guidelines would say we should do that every year. And there are guidelines now saying that all children should have their blood pressure checked every year. But we feel that there's now enough evidence that children and young people with this condition can have high blood pressure to justify suggesting that they should have this checked at least every 2 years. And that's regardless of whether they've been diagnosed with the condition or whether they're purely at risk of it by their family history. Even if they're not formally diagnosed, it's still entirely reasonable for them to go and have a blood pressure check to see if their blood pressure is high. The third recommendation is that we recommend that the decision to test for ADPKD in asymptomatic children and young people, so that's children and young people who haven't presented with a problem, and it's relatively rare to present with a problem from it in childhood, but some people do. So those that are asymptomatic but at risk of developing it, the decision to test should be undertaken jointly between health professionals, the parents or carers, and wherever possible, the young person. And that's really important that we start to take their views into account. And that's obviously more relevant as they get older in age. And that recommendation is important because it really goes against what some people would traditionally say, which is that we shouldn't test children for ADPKD until they're 18 and old enough to decide for themselves. That's not to say that we're advocating testing. What we're saying is that the decision should be made between health professionals and families, and health professionals should no longer be inhibiting testing. If a family and a young person strongly want testing and they've discussed the reasons for that with their clinician, the clinician should be supportive of them in that. And so that's a significant departure from some of the traditional dogma around this condition. And then the fourth recommendation is that if testing is decided on, we suggest that either a kidney ultrasound or genetic testing could be offered where the testing's been agreed upon as per the point above. There's pros and cons to each different type of test, and that's something that can certainly be covered when you see a clinician who specialises in this condition in children, and we can talk to you about the different benefits or negatives of each testing modality. There are some benefits of genetic testing above kidney ultrasound and vice versa, but the guidelines have gone for either because it would be a significant departure from what we do in practice to be offering one or the other. And there's no clear evidence at the moment that one is better than the other. So that's, again, comes back to the first point. It's really important to have a good open conversation with a child's clinician about the pros and cons of each type, because it does depend on a number of factors. So, for example, if a family mutation is not known, it's very difficult to do genetic testing in that child. So the fifth recommendation is that we're suggesting that if children who don't have symptoms but are at risk of ADPKD don't have any cysts on ultrasound, we should delay doing further ultrasounds until they're older. So we said adolescents, so 15 to 18 years here, or later if it's preferred by the young person. And the importance of that recommendation is that a lot of the practice which we found in the previous survey was that some clinicians were doing ultrasound scans every 6 months or every year. And there's no clear benefit to doing that. And it's been shown to actually increase anxiety levels in some people. And so we've made the recommendation here that we shouldn't keep going on and doing ultrasounds all the time. And this would certainly be more consistent with the adult practice where they don't do repeated ultrasounds every year or so. I can see a few questions are coming, so I'll come on to those once I finish this slide, if that's okay. And the sixth point here is that we recommend that if genetic testing is planned, we should identify the mutation in the affected family member, if it's not already known, before we test the child and young person. And that's a general principle in genetic testing, where it's actually a lot easier to identify it in the child or young person if you identify it in the affected adult member first. So I'll open up some of the questions. So the first one here is so the question is about two children aged 5 and 3, both genetically diagnosed, can do normal physical activity or sports, whether this will compromise their cardiovascular system. So in all children that we have in our clinics who have ADPKD, even if they have a genetic mutation that may be considered aggressive, and we can talk, there are different mutations, some slightly worse than others, and we wouldn't want to limit them having normal physical activity at school or in other activities. And we know there are many benefits of physical activity, and so we wouldn't want to limit them in normal cardiovascular exercise. So I've got another question here about if a parent experiences significant symptoms in childhood and the children have inherited the faulty gene, is it more likely that the children also experience symptoms early? So first of all, it's relatively uncommon that children have significant symptoms of childhood in childhood, and most children will have no symptoms at all. We know that in certain families who have certain genetic mutations, that some of them have more cysts and a higher risk of high blood pressure. And so we know that if you have a family member who has a mutation that confers this increased risk, your child might be at slightly higher risk of having blood pressure problems at an earlier stage. But we have no data on symptoms being inherited in the family in this way, mainly because it's relatively uncommon to have severe symptoms in childhood. So I've got a question here from a GP and a PKD patient with sons aged 14 and 16. So the first question is regarding blood pressure for children, because cuffs are not routinely found in primary care unless purchased by practices. And secondly, should we be searching for adults with PKD and sending letters to invite their kids? So this is one of the slight issues with the guidelines that we've produced, is that if they're put into practice, they result in quite a significant deviation from what's already happening in the UK. Blood pressure measurement in children is notoriously difficult. I would say that certainly for 14 and 16, I would hope that most practices would have a child-sized cuff that they could check that with. But it will require a lot of additional resource if we're going to put these guidelines into practice. Because as you rightly say, lots of GP surgeries don't have the resources at the moment to do this measurement. That's not to say that we shouldn't develop guidelines based on the science that we know about. We've developed the guideline. It's now up to us as clinicians, but also policymakers, to see how we can put that into practice. At the moment, we're not suggesting doing searches for adults with PKD and sending letters to invite children, because at the moment we're spreading the word through means like this, but we're not recommending sort of actively contacting people, and that we wouldn't advise that at the moment. So I've got a question here about a cyst in a daughter who was seen on a kidney scan during pregnancy and seen again up till her latest scan. And there is no scan now. Do cysts come and go? So generally, true cysts don't come and go, but scans that are done in children by ultrasound, if anyone's had an ultrasound scan done on a child, they'll know they're notoriously difficult to do, particularly in younger children when they're moving. So it can be that we see a cyst sometimes and then we don't see it on another scan. That's more likely to be a variability in the quality of the scan than a true cyst. And the last question here for now is, what do we mean by an aggressive mutation and how do we know is which? Well, I wouldn't use the term aggressive mutation. I think that was used in one of the other questions, but essentially there are different mutations that you get. The commonest two types in ADPKD are PKD1, which is about 85% of affected individuals, and PKD2, which is about 15% of affected individuals. There are different subgroups within that. And what we know is that those with a PKD1 mutation can sometimes get a decline in their kidney function earlier during adulthood than those with a PKD2 mutation. So what the individual with the question here may have meant is that the type of mutation is associated with a slightly earlier disease onset. There are a very small group of children who have what's called very early onset disease, which is often due to a complex genetic makeup, but that's the minority of children rather than the majority. So that's those questions for now. I'll move on to the next few slides. So the last point here is just where you can find this guideline. If you do want to read it in detail, the science behind why we recommended what we have is up there. And it's just the Renal Association. And if you go to guidelines, you should be able to see it here. I'm very conscious that there are many expert families on this call who like to know about the information on which we've based these decisions. So I just want to talk a bit more about why we recommend checking blood pressure if the young person or their family decides not to test them. So there was an international conference a few years ago now that summarised it was only a very small part of the report, the childhood aspect of this condition, but they summarised that cardiovascular problems in this condition can be found from a young age onwards. And they've recommended that children who have a family history, so those that are at risk, are screened for hypertension, so that's high blood pressure, from the age of about 5 onwards. And they've put an interval of 3 years if we don't find high blood pressure. And then they've talked about how we should treat that. So that's really the first mention in the scientific literature of the fact that we should be checking even those who aren't tested and confirmed for this condition to check that their blood pressure doesn't go up. Oops, sorry. Too many clicks. So about 3 or 4 years ago now, we published this paper where we took all the studies that had reported children and young people with ADPKD, and we summarized the data from them. And we found in the published literature, there are 928 children across 14 studies. The average age was 10 years. And of these, about 1/5 had a high blood pressure. So we know from this data that there is a significant proportion of children and young people with this condition who will have a high blood pressure. Now, I should add the important caveat that most of these studies are done in specialist centres, and specialist centres are more likely to have the children who've presented with symptoms who are generally on the more severe end of the spectrum. So it's important to add that caveat, but that's at the moment the best sort of estimate we have. And in this study, we also looked at the prevalence in each study. So that's the number of, the proportion of children with this condition who have high blood pressure or hypertension. And we found that it increased with age. And that fits with the adult data, which shows that as individuals get older, their chances of having high blood pressure or hypertension go up. And we can see that here. So the data on how many by each age have a high blood pressure will vary depending on which study you see. But we know that cysts progressively develop in the kidneys with age, and we know that blood pressure rises in association with that. This is another study that looked at blood pressure measured with a 24-hour monitor that many people will have. In children, their age was similar, 11 years, and they had over 300 children in this study. And they actually found high blood pressure in 35% of children and young people, so higher than in the estimate from our study. And they also found that they had over 50% of these children had an abnormal blood pressure profile. So normally your blood pressure drops overnight when you go to sleep. And over half of the children in this study with ADPKD had an abnormal blood pressure overnight. And that may be an early sign that things are starting to go a little bit wrong with the blood pressure. So all of this data together makes us think we really need to look at this condition differently and not consider it an adult condition, but really make sure that we're addressing this potential burden of disease during childhood. We were fortunate enough to have a study supported by the PKD charity where we actually recruited 47 children with ADPKD and 49 children who were considered healthy with no health conditions. And we found that those with ADPKD had a significantly higher blood pressure, consistent with the other studies. And we also found again that even if you account for blood pressure changes over age, that increased as they got older. So this was from the survey that I mentioned at the start, and it has an estimate of the number of children with ADPKD who are followed up by each of the nephrology centres, so that's the kidney centres in the United Kingdom who deal with children. And we found that at the highest estimate, around 500 children and young people with this condition were followed up. Now, if you do the maths based on the genetics of the prevalence of this condition, so the chance of having it, 1 in 1,000 people is thought to be affected. Therefore, around 12,000 children and young people are thought to have ADPKD in the UK, and we're only following up about 500 of them in the UK specialist centres. Now, some children will clearly be under follow-up from a local paediatrician which wouldn't have been captured by this, but it's clear that there's a large number of children who are in the community who aren't having any follow-up for this condition, and that was another stimulus to develop these guidelines. But it raises the question that our colleague also mentioned in the questions, which is how do we suddenly start doing all of these blood pressures? Well, the best way really is for families to spread the word and to just talk about this condition, and then they can go to see their GPs or their paediatricians if they're under one, and just talk about the new guidance and start getting children to have their blood pressure monitored. So we're also in the process of starting another study that's led by Paul Wynyard, who many of you will have heard speak before, the hypertension in young people at risk of ADPKD study. And the aim of this study is to try and address some of those issues that I talked about in the studies before, which is that they were done in specialist centres, and therefore they may have overrepresented the number of children with blood pressure problems. So actually it may not be as high as 20 or 35%, it may be lower. And so the aim is to recruit 200 children and young people at risk of the condition, but not diagnosed with it, to try and determine what the true risk of high blood pressure is in this condition. And we're also planning genetic and MRI studies through this. We're going to advertise it through the PKD charity. This is one of the leaflets that will be put out, and there'll also be a website that I don't believe is active yet. We haven't started recruitment yet, but when we do start recruitment, I'd encourage everyone to have a look at this and consider whether they want to be part of this study. Another topic that we often get asked about is about diagnosis and how we do this. And one of the issues with the ultrasound scan, which is one of the commonest ways we diagnose this condition in children and young people, is that there aren't really any clear criteria of what a positive scan means in this condition. So these are the criteria we use in adults. They were published just over 10 years ago now. And to make the diagnosis in adults, we consider more than 3 cysts in total, so that's in one or in both kidneys, from the age of 15 to 39, if someone has a family history. So clearly, if you're younger than 15 and you've got a family history of ADPKD and you've got more than 3 cysts in total, that can make a diagnosis of ADPKD. But it's quite difficult to rule out a diagnosis of ADPKD with ultrasound, partly because it's technically difficult, particularly in smaller children, and partly because some cysts can develop later in the condition. That's particularly true in those who have the PKD2 mutation. So when we talked about different mutations earlier, I mentioned that the PKD2 mutation tends to cause less cyst growth earlier in life and tends to shift the need for any support with kidney function until later in life. And so if you have a child who's at risk of ADPKD and they have a normal ultrasound, that doesn't mean that they don't have the condition. It just means that we haven't yet detected it. And this is exemplified here in this study, where they looked at 185 children with ADPKD. So 19 of them were negative on ultrasounds. They had a normal ultrasound on their first visit with an average age of 6 years. But 16 of these became positive during a later visit at the age of 9 years. So that's one of the problems that we have to talk to people about when we talk about whether we should test, is that actually, particularly in younger children, even if we do an ultrasound, it doesn't necessarily provide the reassurance that people are looking for. And again here, this just demonstrates that issue of the different mutations that I was talking about. So this here is in patients aged 15 to 29. And you can see here that with the PKD2 mutations, many more of those had lower cyst numbers than those with the PKD1 mutations, where there was a higher number of cysts in that condition. So then moving on to whether we should do repeated scans. Well, this is something that the guidelines also mentioned. And we quite strongly in the UK believe that there's no benefit in doing repeated scans if the first one shows cysts. So that's quite clear. Unless there are symptoms or other problems such as urine infections that require a scan for different reasons, if your first scan shows a significant number of cysts and we've made the diagnosis of ADPKD, there isn't really any benefit in doing lots of scans. And as I said previously, colleagues would do scans every year, and all this really does is serve to increase anxiety. The so-called sort of practice of cyst counting doesn't actually relate to any meaningful difference in how we treat children and young people. There is some data that if you have a bigger cyst burden, certainly in adults, you've got a higher risk of things like blood pressure problems. But we should be monitoring the blood pressure anyway. So again, we're quite clear that we shouldn't be doing repeated scans unless there are symptoms or other problems. And what we've said in the guideline in the UK is that if the first scan is negative, we would suggest not doing more scans until someone is older, so later in adolescence or in adulthood. The reason for that is because, again, it can create a lot of anxiety to do a scan every year. And then even if it's negative again, it still doesn't necessarily provide that reassurance. So we would suggest deferring repeat scanning until they're closer to an adult age. Clearly, if they're negative at 15 to 18, they still don't provide total reassurance. But as you get older, the lack of cysts provides some increasing reassurance that they don't have the condition. Genetic testing can provide a more definitive answer, but is difficult in certain situations as well. So I'll just stop to see if there are any questions on the Q&A coming up. About a 6-year-old with a PKD1 condition, mutation and normal kidney function and very itchy skin, and whether that's related. So that's not necessarily related. If the kidney function is normal, there's nothing in the kidney function that would make them have itchy skin, and I would suggest going to see their GP and getting that looked at in isolation. There are many things that are much more common than kidney reasons to have itchy skin, particularly in children, and generally we only see that in children whose kidney function is very, very low. So I wouldn't associate those two things. So I'll talk a bit about what treatments are available for children and young people with ADPKD, and that's something we also get asked about quite a lot in clinic. So at the moment, we don't have any disease-modifying treatments in this population, but there are studies ongoing. And so I always talk to families and tell them about the hope I have for the future with this condition. What we do know is that we should be advising a generally healthy lifestyle and all the normal things that healthy children and young people would do. So that means having a healthy, balanced, low-salt diet. And we know that high-salt diets can exacerbate high blood pressure, which can make kidney conditions worse, particularly ADPKD. And so we'd advise a healthy, low-salt diet. We'd advise normal levels of exercise and weight control as well. So all those normal things that we would advise are important, just as important for children and young people with ADPKD. Many of you will know about tolvaptan. Many of you may also be on the treatment. And this study that came out, I think in 2012 now, really kind of changed the scene in that sense because it provided us with a treatment that actually modifies the disease course. Now, obviously, as paediatricians, we were very interested in this, and we thought, well, if we can actually modify the disease course earlier in life, are we going to give even bigger benefits to our children and young people with this condition? But there are naturally challenges with this. Those of you who take the medication will know about the significant water intake that's required to cope with this medication, and that obviously may be limiting for some children who struggle to get even a litre in every day. This was published only 2 weeks ago now, where they looked at some of the data from the study, and they looked at tolvaptan in adolescents and young adults. So they looked, I think, at the 18 to 24 age group here, and they found similar results, that it does slow the progression of kidney decline in this setting. Now, there is a study underway in the UK and internationally looking at ages 12 to 17. With tolvaptan, we were hoping that study was going to finish this year, but it may be delayed slightly due to COVID. One of my colleagues takes part in that. We haven't got any results yet, but we'll be very interested to see what that shows and whether tolvaptan has some benefits in this condition for children. At the moment, the guidelines don't suggest its use in a wider setting. And again, as I said before, I tell a lot of my families that I have great hope for this condition in the future, particularly for those, infants and babies that I see who are newly diagnosed with the condition. And these are all the different sort of molecular pathways, and the detail of it's irrelevant. I don't understand half of these things. But these are all the different pathways within the cell that are increased or reduced in PKD. And it just shows you all these different targets we might have for medications in the future. Some of them you might know about already. So this is tolvaptan over here and the V2R antagonists at the bottom. But there's lots of other pathways that are either in early studies in mice and animal models, or some of them have even gone through human studies. Now, clearly, not all of these will work, but to me, it just demonstrates the potential in this condition, and particularly as this is a lifelong condition that generally doesn't result in significant kidney decline for many years. I think the future for our young people is bright. So, thinking about this condition in children and young people, it's primarily, as I've said, a disease of blood pressure, so a cardiovascular disease, because that tends to be the main manifestation of the disease in children and young people. We've already talked about the guidelines that have been published in 2019, but there's clearly big financial implications to changing practice. And at the moment, we don't have the infrastructure to do this for all children, but we need to try and raise the awareness of this condition so that families and young people can start going to their GPs and other health professionals and start the monitoring for this. And as I've said already, there are increasing numbers of potential treatment options in the future that provide hope for families and young people. So we've talked about quite a lot of this already, and a few more questions that I've been asked recently. Firstly, is there any reason to diagnose it? And should they be told that they might have it? So lots of families aren't entirely sure how to tell children and young people about the condition. Lots of young people experience the condition through relatives that they have who may be undergoing things like transplantation or dialysis, and it can be really difficult to talk to them about this. And I'll also mention the most common question I get at work at the moment, which is what we should do about COVID-19. So I hope many of you have already seen this, but on the PKD charity website, we've got this guidance that outlines a number of aspects that we've already talked about today about ADPKD and whether they should be tested if they're at risk of it. And we put here some of the advantages and disadvantages for that. Every family is different, every individual child and young person is different, and every family functions in a different way. And that comes back to one of the main recommendations, I think number 3 in our guideline at the start, which is that this is a decision that has to be made by the family and the young person in conjunction with their healthcare professionals. And we shouldn't be paternalistic, and we shouldn't be telling you what to do. Either way, we shouldn't be telling you not to be tested. We also shouldn't be telling you to be tested. It's about giving you the information that you need to make the best decision for your family and for the young person in question. And also there's some helpful guidance on the PKD charity website about how to talk to children and young people about ADPKD, how to think about the implications of this for them. And here as well, some tips about what parents and families have found helpful, and some of the benefits and drawbacks to talking to them about the condition. So I'll just briefly mention COVID-19, as I'm sure many of you have been worried about this for yourselves and for your children potentially. What we're seeing, so we're very fortunate at Great Ormond Street, we don't have any adult patients, we don't have an emergency department, so we've seen very little of this. And what's quite clear from the data, not just from China and Italy, but also now from the UK, is that children appear to be at significantly lower risk of severe disease, particularly when compared to adults, and particularly compared to adults who have chronic health conditions. There are a number of reports that have come out of severe disease in a small number of children, but I would emphasize that these cases are really rare, and the reason they reach the media is because they are uncommon. And what we're actually seeing is, sadly, we're seeing children coming to a degree of harm because of other conditions, and because they haven't sought healthcare as early as they would have done because they're worried about COVID. So we've unfortunately seen a number of children come in very sick with other infections, such as meningitis or sepsis, because they've been worried about coming to hospital, and so they've left it until the last minute. There have been I think a few, the numbers change, but a handful, sort of 3 or 4 deaths from COVID-19 that have been associated in children. But there have sadly been hundreds of deaths in children from other causes over the last few months. So I think it's really important just to bear in mind that this disease, whilst it can cause very severe disease in adults on a population level, it doesn't appear to affect children significantly from what we know now. So we would recommend for our children who have ADPKD, who are otherwise well, to follow the current government advice. We wouldn't give any different advice, and that's what I tell families every day when I see them. The British Association for Paediatric Nephrology has produced guidance for those who are on dialysis or immunosuppression, so that's medications that reduce your immune system's function. But currently, none of our children at Great Ormond Street would fit into this category, and it would be very unusual to be in this category if you had a straightforward case of ADPKD. So we would just advise following the normal government advice at the moment. Return to school is clearly a highly debated issue. The situation changes on a day-to-day basis. And so as soon as I give this talk, it will probably become out of date. But again, what I've been saying to our families is just to follow the current government advice. Now, clearly, if we've talked about how children and young people are at lower risk, but many of them, particularly with this condition, will live with adults in the household who are at higher risk, particularly if they have things like kidney transplants or on dialysis. And that's a difficult situation. And that's one where we have to really look at it individually. And the adults have to speak to their kidney team and work out what the best advice is at that point. And as I say, it's, we can be reassuring about the impact on children and say that we don't feel that there's a significant risk to children of going back to school if they have ADPKD, but there clearly may be a risk to the adults in the household who may be shielding. And that's something that we wouldn't want to obviously impact on. So I think it's a discussion for all adults to have with their kidney team when the time comes to be returning to school, which may be next week, and it may be only for a small number, but will clearly be very, very relevant for some families. I just want to sort of finish by saying that whilst this is clearly a very sad situation that's brought about a lot of heartbreak for many families, the pandemic is starting to bring about some positive change for healthcare systems. I did a clinic this morning where I did video visits, and actually a lot of the consultations we do now can be done remotely, and it's almost forced us to make some changes that we probably should have done earlier. And I hope that will, in the long term, stay with us and will become more patient-centred and will enable more families to speak to specialist teams and see specialist teams who they may not have seen previously because of distance or other factors. I can see a few questions have started coming through, and please do feel free. I think those are all of the questions, all of the slides I had to cover. So I've got a question here about what advice would you give for a child with stage 3 CKD with ADPKD about returning to school? So first of all, to have ADPKD and stage 3 CKD is relatively unusual, and that's I can't think of any children with straightforward ADPKD in our population who have that stage of CKD, so chronic kidney disease. But at the moment, for our children who have stage 3 chronic kidney disease, we haven't advised any modifications, and so we would still follow the normal government advice for individuals with that problem. So stage 3 chronic kidney disease, we would follow the standard government advice for children. And then the second question is another question from a GP colleague. And if the genetic mutation is already known, would it be best to refer children for nephrology opinion and genetic testing rather than a GP arranging an ultrasound for cysts? Even if the blood pressure is normal. So I guess the two questions there. The first is how do we test in this family? And the second is should we test? The first thing is if the family and the young person would like testing, then that's a discussion that we could have. So I would advise referring them for a nephrology opinion or a paediatrician with an interest in nephrology so that they can have that discussion with us about the pros and cons of testing. And then we can also talk to them about the pros and cons of testing. If the child is younger, certainly if they're under 5 years of age, an ultrasound might not be reassuring, as I've said before. You might get a normal ultrasound, but they may still have the condition. And if the family mutation is already known, it may be that we can go ahead with genetic testing. And that depends again on where you live and which centre you go to and how available that is. So that's why I think it would be worth seeing a a paediatrician with an interest in nephrology or a paediatric nephrologist to have that discussion. So another question's just come through. Twins that will be 5 in September. One has been diagnosed since age under 1, and the other one was misdiagnosed a couple of years ago. But there's still a 50% chance in them developing it. How can I go about a genetic test? So I'm not quite sure I understand what misdiagnosis means. If that means that they were negative on an ultrasound but may still have the condition, then it may be that a further ultrasound later in childhood is an appropriate option. Again, as I say, individual areas are doing genetic testing differently. I would advise going to see your consultant that you see and speaking to them. You can have a look. As I said, the UK guideline is on the Renal Association website. So if you just go to Renal Association and guidelines, you should be able to find it. And that's something that we're now advising people to use, because it does empower you, I think, to get to have at least have a discussion about the pros and cons of different testing type. So another question here, what are the earliest signs to look out for in young children who've had the genetic test and have inherited? So in terms of signs to look out for, most of the children we see with this condition don't have any signs or symptoms. So there wouldn't really be anything to look out for in particular. And we know that blood pressure, again, is silent in almost all children and young people with this condition. So they wouldn't have symptoms from the blood pressure. So the important thing really is to have them seen, and we've said at least every 2 years, and have their blood pressure checked. So that applies to those who aren't diagnosed, but certainly applies to those who have been diagnosed and have had a genetic test. And then we make sure that their blood pressure is okay. If they don't otherwise have symptoms and their blood pressure is normal, there's nothing we need to do in terms of action. So that's all I would recommend. From time to time, their doctor might decide to do blood tests. That's entirely reasonable. But we know that even in children and young people with high blood pressure, most of those will still have normal kidney function. So blood tests certainly aren't required every year in this condition. Another question here, what cases of ADPKD would be referred to Great Ormond Street and which would be managed by a local nephrology team? So I would say that we are a local nephrology team for North London and above. There are 13 children's nephrology centres in the UK, all of which would have ample experience and knowledge of managing this condition. So there's no additional reason to be referred to Great Ormond Street to have this condition managed. It's just that we happen to be the centre for North London, but lots of teams would be able to manage this entirely themselves. And lots of local paediatricians, so not even paediatric nephrologists, but local paediatricians who have an interest in nephrology would be also entirely able to manage this. So another question here, our renal team have previously said that they will not scan young people under the age of 21. How can we force the issue for an older teenager? Well, if your renal team is an adult team, they may have different criteria and different rules. It's difficult to force any issue. Again, I would say that the guidelines are out there on the internet. They've now been published and approved, and they're accredited by NICE, so the National Institute for Clinical Excellence. So we would advise families to have a look at those and then discuss those guidelines with their clinical team to try and understand what the reasons are. As I said, there are lots of historical views about whether we should or shouldn't test young people, and we're trying to change those views, but that takes time. And the guidelines, as I say, have only been out for, well, around a year now. So I think that's all the questions for now. I think that's also the last slide I had. So Tess, I didn't know if you wanted to ask anything, or if any more.
Yes, apologies. If anybody's hearing a whistle, I'm using a very old computer, unfortunately. We did have a couple of questions that came by email, Matko. One was the reference to diet, and the other one, we've answered most of it, but there was a question about pain for a young woman around period time.
Yes.
What might be recommended. So if you wouldn't mind, I'll go on mute again and let you answer those two.
I can also see that there's a hand raised, so we can come on to that in a second. But in terms of the diet, there is some data now certainly I think one of them from a study in mice or animals, that certain types of diet can change cyst growth in ADPKD. So as I said before, what we would advise is a normal, healthy, balanced diet, a low salt diet where possible. As I say, there's a paper that was sent from last year that talks about something called a ketogenic diet. And what I would say is that we currently don't have any good clinical evidence of which diets would be beneficial in this condition. So we wouldn't advise a specialized diet. And the international guidelines on this condition also do touch a little bit on that, but state that there is no reason to significantly adapt the diet, and we have no scientific evidence to suggest that that's a good thing to do. We also wouldn't restrict protein intake excessively, and that's something that in kidney conditions has been done previously, because in children and young people that can have an impact on growth that we obviously don't want to cause. And then I think the other question that I saw was about I'm just getting it up, about pain. So yes, so pain around the kidneys related to the period. So as I said before, symptoms and pain in particularly are really uncommon in children and young people on an overall level, but clearly very frustrating and difficult for those who are experiencing them. What I would say is in those situations where there is significant pain or any other symptoms, that might be a reason to do another scan. So the guidelines I talked about were for general situations where children and young people are well with no other additional problems. But if they're unwell, if they're symptomatic, then we may need to do a scan. We may find that there's bleeding into a cyst. In this case, what the international guidelines would also say about this condition is that pain in the abdomen, so pain in the tummy or around that area, in children and young people is quite common from lots of other conditions. And so if you're having lots of pain, it's important to rule out all the other things that can cause pain in children and young people and not just put it down to the PKD. Because as I say, it's very uncommon to get pain just from the PKD in young people. So it's important, if it's related to periods, to have a full review with the GP or whichever other doctor the individual sees, and make sure that it's not related to things like the ovaries or something like that, and particularly if it's related to periods. So we wouldn't want people to assume that things like pain are due to PKD, and we will want them to get seen and get that checked out properly. I'm just having a look at the chat to see if there's anything there. So I've got one extra question here about 4-year-old with cysts on both kidneys. And then next scan, they said they didn't have any. Do they just disappear, or could it be a clear scan? So as I think I said before, scans are difficult in young children, and there's a bit of variability depending on who does the scan. So if a cyst was seen to be there and then has disappeared, it's most likely that it wasn't truly there in the first place. They don't generally disappear, and certainly the bigger ones don't. It is possible in theory, but the important thing would just be to keep under some follow-up, keep getting those blood pressures checked, and then at some point in the future, as decided by a clinician, to do another scan. But it would be reassuring if it didn't then reoccur on other scans. So I think that's all the questions I've got now. Thank you very much to everyone for listening. It's great that you've given up your evening to come and hear me talk, and I hope I've raised some awareness about this condition, and I hope it's been helpful.
Thank you, Matko. I think, given there are no more questions, and I can see just a couple of people saying thank you in the chat. In that case, we will finish a little bit early. And of course, you can send any follow-up questions to me at info@, and we'll be sending around a little survey just to get your feedback on the webinar and suggestions for future webinars, of course, so that helps us plan our programme of support. Great, thank you, and very good night to everyone. Bye all.
Thanks a lot.